Hi, this is Brian Kim. I'm going to share with you this case where I perform an intraocular lens exchange. This patient had a Restor 3.0 multifocal and was complaining of waxy vision. And so we decided to try exchanging him for a Panoptix trifocal lens. And so I will show you kind of systematically how I'm able to open up the bag and put this new lens for this patient. So the first thing you'll notice is that this patient has 360 degrees of capsule overlap. And so this is important so you can be able to get underneath the anterior capsule in order to separate the lens from the bag. So I'm going to make my paracenteses incisions. I use a cotton tip to turn the eye and make the incision parallel to the iris plane to get a nice shelf. I do the same thing on the other side using the cotton tip to turn the eye so I can get a flat approach, making an incision parallel to the iris plane. I inject intracameral lidocaine to anesthetize the eye, and then I'm injecting dispersive viscoelastic into the anterior chamber. I'm not doing an overfill because you don't really need to. This is not cataract surgery. So then I'm going to make my temporal incision. I'm using a 2.6 millimeter keratome blade, making a cut through the limbus and then tunneling and then entering the anterior chamber. I prefer using a needle. I'm using a 25 gauge straight needle, 1/2 inch. People might be scared of causing a problem with the needle, but the reality is this is not an issue whatsoever. You won't puncture the capsule or rip the capsule, especially in a lens that's been in there for several months. If it's early on, you don't need a needle. You can just go straight to the cannula and open up the bag. But if it's been a little while, you can use the needle to get right underneath the anterior capsule edge. And you want to turn that bevel down, and you want to get that edge of the needle right against and underneath the anterior capsule. Once you get underneath the anterior capsule, you sweep side to side, and as you sweep side to side, you inject dispersive viscoelastic. This will create a mass effect and lift the anterior capsule off the surface of the lens. You want to do this same procedure 360 degrees going all the way around. Again, you're pushing the bevel down against the anterior lens surface, and this helps you get underneath the anterior capsule edge. You're able to viscodissect the anterior capsule off the lens. Now I'm going around circumferentially and using a cyclodialysis spatula to again separate the anterior capsule off of the surface of the lens, and I'm doing this circumferentially. It's very important that you use a blunt instrument to kind of tease off the anterior capsule from where you viscodissected the anterior capsule off the lens. And so I'm just going around 360 degrees, ensuring that I have a really nice separation of the anterior capsule from the lens. You can see that the needle did not penetrate or cut the anterior capsule at all. You have a completely intact anterior capsule. Now I'm actually injecting cohesive viscoelastic further into the capsular fornix, and you can see that viscoelastic went around the lens, and you can see it's actually between the lens and the posterior capsule. I'm going around teasing and pushing a little bit of that cohesive viscoelastic circumferentially. You don't want to inject vigorously and create a large bolus. You're just creating a little bit of mass effect to cause, again, more viscodissection, separating the anterior capsule from the posterior capsule, a little bit further, more peripheral from the lens. This sweeping maneuver really makes sure that the anterior and posterior capsules are completely separated from one another into the capsular fornix. Once you're sure that the anterior and posterior capsules are separated, you're able to use a Sinskey hook and lift that haptic out of the bag. In this case, the haptic was not really fibrosed into the capsular fornix. If it was, as I tried to lift the haptic out, it would have been snagged. You would see traction on the capsular bag, and you'd have to stop and consider amputating it. In this case, that didn't happen, and this patient had surgery roughly about a year ago. I'm using the Sinskey hook to lift the other haptic out of the bag, and you can see it's just kind of slipping back into the bag, but then I'm able to grab it and then lift it up anterior to the iris plane, and then I'm manipulating the lens so that I'm making sure that the lens is entirely in the anterior chamber. Now I'm going to use the forceps and scissors. I'm using the scissors in my right hand to gently manipulate and lift the optic up so I can grab it with the lens holder. And as I'm able to grab it with the lens holder, I'm able to cut the lens with the scissor. Again, I'm using the closed teeth of the scissors to bluntly manipulate the lens so I'm able to grasp the lens holder in my left hand. And I turn the teeth of the scissors more sideways so I don't go near the posterior capsule as I cut it. And you can see I was able to cut it completely in half. I'm still holding the lens with the forceps in my left hand. I'm switching from the scissors in my right hand to another forceps, and I'm going to grasp the haptic and then pull it out of the incision. By doing this, the haptic won't fold out of the eye uncontrollably. Now that the haptic's out, I grasp the cut edge of the optic, and I'm able to deliver that first half of the lens fairly atraumatically using the forceps. And then use the forceps to grasp the cut end of the other second half of the lens. By grasping the cut end of the lens, it will come out at its most narrow part of the lens through the incision. I'm injecting some cohesive viscoelastic very gently to fill the bag, and then I'm going to deliver the Panoptix lens through the injector. I'm going to inject the lens fairly slowly because, again, this is a fibrosed bag. You just never know what's going to happen when you're putting a lens in a second time. This is not like delivering a lens in the virgin eye that's just had cataract surgery. Sometimes these bags are just not very predictable. And so thankfully this lens delivers fairly easily. I have part of it in and out of the bag. I'm going to use my BSS cannula to just manipulate the haptics. You can see the haptics are holding each other. I'm able to disengage the haptic and the leading haptic goes into the bag, and I'm manipulating the trailing haptic to make sure it's completely in the bag. I switch to the INA. I make sure I go underneath the optic, tilting it a little bit, remove the viscoelastic between the lens and the posterior capsule. Once the viscoelastic is completely removed out of the bag, I remove the viscoelastic from the anterior chamber, push BSS as I pull out with the INA, and I hydrate my incisions. So you can see this is an IOL exchange. I use a 25 gauge needle with dispersive viscoelastic, specifically Viscode. I don't recommend using Cellugel or methylcellulose. I think it causes too much of a physical mass effect. Viscode is a little bit better about being able to dissect between the anterior capsule and the lens. Using that bevel down approach will allow you to get that sharp edge of the needle bevel right up against the lens surface and wiggle it underneath the anterior capsule. You're able to sweep side to side. This will not puncture the capsule because the capsule has some strength and fibrosis. With the time interval after surgery, you're able to sweep side to side, inject the Viscode, which will cause a little bit of viscodissection. You can use a cyclodialysis to sweep underneath it even more, and then again use some more viscoelastic and push it further into the capsular fornix, separating the anterior and posterior capsules, as well as the haptic from the bag. You're able to prolapse the haptics up using a Sinskey hook and then bisecting it with intraocular forceps. Again, a single piece acrylic lens comes out very easily in this situation, and this patient did very well. So I hope this was helpful to you. Please like and subscribe, and I thank you for your attention.